The pharmacy counter exchange happens so fast most people forget it by the time they're back in their car. A white paper bag slides across the counter. Same as last time, the pharmacist says, already reaching for the next customer's file. And remember, plenty of water with this one. It's rough on the kidneys if you run dry. The person on the other side nods, already checking their phone, already thinking about the drive home, about the rest of the errands, about anything except the sentence that was just said to them in passing, the way you'd mention traffic on the highway. That exact exchange happens something like several million times a day in this country. A small, true warning, delivered fast, absorbed by almost nobody, about an organ most people haven't thought about since a biology class decades ago. I want to talk about that organ tonight, because it is, without much competition, the hardest working and least discussed part of the human body. It filters your entire blood supply, all of it, roughly 40 times a day, quietly, without a single symptom, right up until the point where it can't anymore. And a surprising number of the things doing the damage aren't dramatic. They're not illegal, they're not exotic, they're not hiding in some suspicious corner of your life. Several of them are sitting in your medicine cabinet right now, completely legal, some of them without even needing a prescription, one of them possibly marketed to you as natural. Tonight I'm counting down 9 of them, and I'm going to end on the one that, if you've watched anything else on this channel, is going to connect to something you already know in a way I don't think you're expecting. I'm Dr. Walter Hale, nearly 4 decades of practicing medicine, and if there's one lesson that's been driven into me more than any other, it's that kidneys fail quietly. The National Kidney Foundation estimates that roughly 1 in 3 American adults is at risk for kidney disease, and a large share of those people have no idea because kidney function can decline by more than half before a single symptom shows up. Half. Gone, silently, before you'd ever think to ask about it. Before we get into the list, tell me in the comments, honestly, when's the last time you actually saw your kidney numbers, the actual creatinine and eGFR values, not just a nurse saying everything looks fine? I ask because in my experience, the answer is almost always, I don't know what those words mean, and that alone tells me something important about how this conversation usually goes. Let me give you the short version of what your kidneys are actually doing, because once you understand this, the entire list stops feeling random and starts feeling like exactly what it is. Each of your kidneys, and you have 2, about the size of a fist, contains roughly 1 million tiny filtering units called nephrons. Together, they process something like 40 to 50 gallons of blood every single day, filtering out waste, balancing your fluids, regulating your blood pressure, and quietly deciding what stays in your body and what leaves it. Every medication you swallow eventually passes through this filtering system too, sometimes in its original form, sometimes broken down into other compounds along the way, and the kidneys have to handle all of it on top of their regular workload every single day for your entire life. Here's the part that matters most for tonight. Certain drugs don't just pass through the kidneys. They actively stress the exact structures doing the filtering, sometimes by narrowing the tiny blood vessels that feed the nephrons, sometimes by directly poisoning the filtering cells themselves, sometimes by throwing off the delicate balance of fluid and minerals the kidneys depend on to function properly at all. Your kidneys have significant reserve capacity built in, which is exactly why this kind of damage is so easy to miss. You can lose a large percentage of your kidney function and still feel completely normal because the remaining healthy tissue quietly compensates right up until it can't. Age itself works against you here too, and I want to be straightforward about that rather than tiptoe around it. Kidney function naturally declines somewhat as we get older, even in people with no diagnosed disease at all, which means the same dose of the same medication that was perfectly safe at 40 can put real strain on a 70-year-old's kidneys. Diabetes and high blood pressure compound this further, since both are, independently, leading causes of kidney disease in this country. None of that means you're destined for kidney trouble. It means the margin for error gets a little thinner with time, and that's exactly why this list is worth hearing all the way through, not skimming. Let's start with number 9. Number 9, over-the-counter pain relievers, specifically ibuprofen and naproxen, the ones sitting in nearly every medicine cabinet in America. These drugs, called NSAIDs, work by blocking certain chemicals involved in inflammation and pain, which is exactly why they're so effective for a sore back or a headache. But those same chemicals also help keep blood flowing properly through the tiny vessels that feed your kidneys, especially when you're even mildly dehydrated. Block them regularly, especially at higher doses or for more than just a day or two, and you can measurably reduce blood flow to the kidneys, which over time contributes to real, sometimes permanent damage. The reason this one opens the list isn't that it's the most dramatic, it's that it's the most invisible, precisely because it's sold without a prescription, precisely because everyone assumes over-the-counter automatically means low risk. The National Kidney Foundation is direct about this. Regular, frequent use of NSAIDs is one of the more common preventable contributors to kidney damage they see, particularly in people who are older, already living with reduced kidney function, or taking these pills daily for chronic pain without ever mentioning it to a doctor because, in their mind, it's just an over-the-counter pill, not a real medication. If you're reaching for ibuprofen or naproxen more than occasionally, that's worth a specific conversation with your doctor, not a decision made silently in the pharmacy aisle. Number 8. Chronic, high-dose use of calcium-based antacids, the chewable tablets people reach for constantly for heartburn. This one surprises almost everyone, including plenty of my colleagues who trained before it became well documented. There's a real, named condition called milk alkali syndrome, and it's making something of a comeback specifically because of how widely available and heavily marketed over-the-counter calcium carbonate antacids have become. Take enough of them, often enough, and calcium levels in the blood can climb high enough to directly impair kidney function, sometimes acutely, sometimes gradually enough that nobody connects the dots for months. What makes this one particularly sneaky is the framing. Calcium sounds healthy. It's marketed as good for your bones, and in reasonable amounts through food, it generally is. But an antacid taken 6, 8, 10 times a day because heartburn keeps coming back is a very different exposure than a glass of milk. And almost nobody thinks to mention I've been eating a roll of these most days at a regular checkup, because it doesn't feel like the kind of thing worth bringing up. If heartburn has you reaching for antacids most days of the week, that's not a personal habit to just manage quietly. That's a symptom asking for an actual evaluation and possibly a completely different medication that doesn't carry this same risk. Number 7, and this is the one I mentioned at the very top, the one that doesn't even announce itself as medication. Certain herbal and natural weight loss or traditional remedy supplements containing a compound called aristolochic acid. I want to be precise here because this one deserves precision. Aristolochic acid comes from certain plants long used in some traditional herbal preparations and unfortunately was also found for years in certain weight loss supplement blends sold in the West before the connection was understood. It is directly, unambiguously toxic to the kidneys, capable of causing severe and sometimes irreversible damage, and it has been documented in medical literature for decades under names like aristolochic acid nephropathy. First traced after a cluster of unexplained kidney failure cases in Europe, were eventually linked back to a contaminated weight loss regimen. The reason this belongs on the list isn't to cast suspicion on herbal medicine broadly, plenty of which is fine. It's that natural has become, in a lot of people's minds, a synonym for harmless, and that assumption specifically is what makes this one dangerous. Nobody researches a supplement they were told is natural the way they'd research an actual prescription. If you're taking any herbal weight loss product, any traditional remedy from an unregulated source, or honestly any supplement whose full ingredient list you couldn't recite from memory, that's worth bringing to an actual doctor, by name, not just mentioning in passing. Number 6. Long-term daily use of proton pump inhibitors, the acid-reducing medications people take for chronic heartburn and reflux, often for years without anyone reassessing whether they still need them. These medications work well, and for many people they're genuinely appropriate. The concern isn't short-term use. It's the pattern researchers have increasingly documented, including work out of Washington University School of Medicine, connecting years of continuous daily use with a meaningfully higher risk of chronic kidney disease over time, independent of other risk factors. The exact mechanism is still being worked out, but the association has shown up across multiple large studies now, consistently enough that it's changed how thoughtful prescribers approach long-term refills. What makes this one worth flagging specifically is how automatic these refills become. A prescription written years ago for a short-term problem quietly turns into a permanent daily habit, refilled by pharmacy autopilot, never actually revisited. If you've been on the same acid reducer for years, that's a legitimate, specific question for your doctor. Do I still need this, at this dose, indefinitely, or was this only ever meant to be temporary? Quick pause here, genuinely, because we're only through 4 of 9 and the next ones are where this really connects together. If this is landing for you, hit subscribe. It helps more people catch this before a routine lab result surprises them. And tell me honestly in the comments, how many of the pills in your own cabinet right now would you actually be able to name if I asked you what each one does to your kidneys specifically? Number 5, diuretics. The so-called water pills prescribed for high blood pressure and fluid retention. Diuretics work by helping your kidneys release more sodium and water, which lowers blood pressure and reduces swelling, and for a huge number of people, they're an appropriate, well-established treatment. The risk isn't the medication itself so much as what happens around it. Dehydration, particularly during hot weather, illness, or simply not drinking enough, can compound with a diuretic's effect and reduce blood flow to the kidneys sharply, sometimes fast enough to cause acute injury within days. This is exactly the kind of risk that hides in plain sight because the medication has been working fine for years. Nobody expects a pill they've taken safely for a decade to suddenly become dangerous, but circumstances change even when the prescription doesn't. A summer heat wave, a stomach bug, a few days of not eating or drinking normally. If you're on a diuretic, knowing that plainly and adjusting your fluid intake during illness or extreme heat rather than just continuing on autopilot is a small habit that genuinely protects you. Number 4, and this is the one where 3 separate things this list has already covered collide into something doctors actually have a name for. The combination of an NSAID, a diuretic, and a blood pressure medication called an ACE inhibitor or ARB, all taken together. In medicine, this combination has earned its own nickname, the triple whammy. Each of these 3 medication types can be perfectly reasonable on its own. The danger is specifically the combination, especially layered on top of even mild dehydration. The NSAID narrows blood flow into the kidney. The diuretic reduces the fluid available to keep that blood flow adequate. The ACE inhibitor, or ARB, which normally protects the kidney over the long run, changes pressure dynamics inside the kidney's filtering units in a way that, combined with the other 2, can tip a stable kidney into acute injury within days, sometimes without much warning at all. Let me tell you what this actually looked like for a patient I think about often, a man I'll call Gerald, 74, from a small town outside Reno, Nevada. He's a composite, drawn from a number of similar cases over the years rather than one specific person, so there's no privacy concern here, but the pattern is one I've seen play out almost identically more than once. Gerald had been stable for years on a diuretic and an ACE inhibitor for his blood pressure, doing fine, nothing alarming at his regular checkups. One July, he threw out his back doing yard work in triple-digit heat, started taking ibuprofen every few hours for a week straight to keep working through the pain, and simply wasn't drinking enough water in the heat on top of it. By the following weekend, Gerald was exhausted, confused in a way his wife described as just not himself, and barely urinating. In the emergency room, his creatinine, the standard blood marker of kidney function, had climbed to nearly 4 times his normal baseline. He was, in every meaningful sense, in acute kidney failure, caused not by one dangerous drug, but by 3 ordinary ones, stacked together during one specific week of heat and dehydration and a hurting back. Gerald recovered, largely, After several days of IV fluids and careful monitoring, and his kidney function eventually returned close to his prior baseline, though not entirely. He tells people now, plainly, that he had no idea those 3 pills together could do that, because individually, every single one of them had felt completely routine for years. If you are on both a diuretic and a blood pressure medication, adding regular ibuprofen or naproxen on top, especially during illness, heat, or reduced fluid intake, is exactly the combination worth asking your doctor or pharmacist about directly, using the words triple whammy if you want their immediate attention, because it will get it. Number 3. Certain antibiotics prescribed without the dose being adjusted for a patient's actual kidney function. Several commonly used antibiotics are cleared from the body primarily through the kidneys, which means the correct dose depends heavily on how well those kidneys are currently functioning, not just on body weight or age alone. When a prescriber doesn't have current kidney function numbers on hand, or when a patient is seeing an urgent care doctor or a specialist who doesn't have the full picture of their kidney history, doses are sometimes calculated using a generalized standard rather than what's actually appropriate for that specific person, and the drug can build up in the bloodstream to levels that directly stress or damage the kidneys. Hafindet. This connects to something I've said on this channel before, and I'll say again plainly. When your care is split across multiple doctors who aren't fully talking to each other, gaps like this are exactly where problems slip through, not because anyone is careless, but because nobody has the complete picture at the moment a prescription gets written. If you're prescribed a new antibiotic, especially by a doctor who isn't your regular primary physician, it is entirely reasonable to ask directly whether your kidney function was factored into this specific dose. Number 2. Phosphate-containing laxatives and bowel prep solutions, particularly the oral sodium phosphate products used before colonoscopies or for chronic constipation relief. This is one the FDA has actually issued specific warnings about because concentrated phosphate loads can cause a real, documented condition called acute phosphate nephropathy, where phosphate crystals form directly inside the kidney's filtering structures and cause damage that in some cases doesn't fully reverse. The risk climbs meaningfully with age, with pre-existing kidney issues, and with dehydration, which is exactly the state most bowel prep regimens put a person into by design. The reason this one lands at number 2 is that it's almost always treated as a routine, forgettable inconvenience, the unpleasant part before a colonoscopy that everyone just gets through, rather than something worth a real conversation about alternatives. If you're facing a bowel prep and you're over 60, on blood pressure medication, or have any known kidney concerns, it's worth directly asking whether a non-phosphate alternative is appropriate for you specifically, rather than defaulting to whatever's handed to you. Now, number 1. I told you at the start this one would connect to something else, and here it is directly. Bisphosphonates, the class of medication most commonly prescribed for osteoporosis, the exact condition we spent an entire video on not long ago. Bisphosphonates work by slowing the cells that break down bone tissue, which is genuinely effective at reducing fracture risk, and for a great many people they're an appropriate, well-studied treatment, but they are cleared from the body through the kidneys, and in someone whose kidney function is already reduced, whether from age, diabetes, or simply not knowing their numbers, these medications can accumulate and place real additional strain on kidneys that may already be quietly compromised, sometimes worsening the very decline nobody had detected yet. Here's what I actually want you to sit with. If you watched that earlier video, absorbed the numbers around osteoporosis, and walked away thinking about your bones, that's the right instinct, but it's an incomplete picture without this piece sitting right next to it. Every medication decision in the body connects to every other one. Treating the bones without ever checking in on the kidneys that will be asked to process that treatment for years is exactly the kind of gap that falls through the cracks between specialists who never spoke to each other. If you're on a bisphosphonate or being started on one, asking specifically whether your kidney function has been checked recently and whether it's being reconsidered as you age isn't a paranoid question. It's the obvious one nobody remembers to ask. I don't want to leave you sitting with 9 reasons to be afraid of your own medicine cabinet, so let me balance that out, honestly. Kidneys are remarkably resilient organs. Even meaningful damage, caught early, can often be stopped from progressing further, and in some cases, kidney function partially recovers once the offending medication or combination is identified and changed. This isn't a list built to make you afraid of your own medicine cabinet. It's built to make you an active participant in a conversation that, for most people, simply never happens because nobody ever brings it up first. A simple blood test, the one that measures creatinine and calculates your eGFR, is the single clearest window into how your kidneys are actually doing, and it's almost always included in a standard annual blood panel, whether or not anyone walks you through what the numbers actually mean. Here's exactly what I'd want a family member of mine to do this week if they were watching this instead of me telling them directly. First, ask for your actual creatinine and eGFR numbers at your next appointment, not a summary, the real values, and ask what they were a year ago for comparison, because the trend over time matters more than any single number in isolation. Second, make an honest list of everything you take regularly, including anything over the counter, anything herbal, anything you wouldn't normally think to mention because it doesn't feel like real medicine. Bring that full list to your primary doctor specifically to review against your current kidney numbers. Third, if you take a diuretic and a blood pressure medication together, treat regular NSAID use as a direct question for your doctor rather than a personal decision, and pay attention to your fluid intake specifically during illness, heat, or reduced appetite. Fourth, if you're facing a new prescription from any doctor who isn't your regular physician, whether it's an antibiotic, a bowel prep, or anything else, it's entirely fair to ask whether your kidney function was part of that decision. Of these 9, which one genuinely surprised you? Tell me in the comments, and tell me if you're the kind of person who's actually going to ask for those numbers at your next visit, or the kind who's going to mean to and forget. I want to know, honestly, which one you are, because next time, I'll ask you to prove it. If tonight was useful, subscribe, because next I'm covering the nighttime habits, quietly raising your blood pressure while you sleep. And given how much blood pressure medication came up tonight, that one connects here more than most people would expect. This is educational information, not a diagnosis, and only your own doctor, with your own numbers in front of them, can tell you what actually applies to you. I'm Dr. Walter Hale. Next time someone hands you a bag across a counter and adds one quick sentence at the end about water, or dosage, or how often, don't already be reaching for your phone. That sentence is usually the only warning you get, and now you know enough to actually hear it.